Dr. Bashir Ahmed Char, Professor and Head of Department of Neonatology at SKIMS, Srinagar. Dr. Muzaffar Jan, Professor and Head of Department of Pediatrics at Government Medical College, Srinagar. Also, I would want to welcome Dr. Misbah, the moderator for the session. He's the Program Manager for Child Health at NHM and also is the Divisional Nodal Officer for the Division of Kashmir. I would request all of you to keep on tweeting on the hashtag MCH Conclave Jammu and Kashmir, your questions, your ideas, any tweets which we can be awarded for the new for the tablet. Thank you.
Thank you, Shweta. I welcome on behalf of NHM, I welcome all the panelists and delegates to this first MCH Conclave held at SKC. Just to give an overview about achievements under child health and RBSK program in UT of J&K, Jammu and Kashmir has seen a remarkable improvement in the number of infant deaths since the start of NHM. And as per the release SRS 2020, 3-point decrease has been shown for infant mortality rate from 20 to 17. And I will add here that pre-NHM, we didn't have much facilities available at secondary and primary level. That is vis-a-vis SNCUs, NBSUs, and NBCCs. We have 27 SNCUs functional at various district and CSC levels. 4 NICUs we are augmenting and we are giving full support at CMCs. 65 newborn stabilization units have been established till date in the UT till date, and 264 newborn care corridor units have been established at various delivery points. HBNC and HBYC has been successfully implemented in all districts of J&K UT, and every year approximately 86% of the newborns are visited under HBNC and HBYC by ASHAs. Regarding NRCs, 6 NRCs have been established at GMC and district level. In addition to this, more importance is given for mother absolute affection, and it has been implemented in UT. And during last financial year, 93.2% newborns have been breastfed within 1 hour of birth, as per as HMIS portal. Then I shortly will say something about National Deworming Day, and yesterday also we saw that because of anemia, National Deworming Day has been instrumental in curbing down the helminthic and being the main issue in the iron deficiency, anemia, and work industry. So it is also properly administered, and 41.9 lakh children and adolescents were administered albendazole tablets in the last round. ITCF, that is Intensified Diarrhea Control Fortnight, is also being, in fact, it will be starting in the month of June, this month only from 13th of June, and 18.65 lakh children, that is 81.3% of children of the UT have been provided ORS during May-June 2021 round of ITCF. RBSK, as you know, we have 216 RBSK mobile teams in the UT who are conducting healthcare checkups of children in the age group of 6 weeks to 18 years. Also, in addition, we have 22 district early intervention centers, whereas we have state-of-art TIC at SMHS hospital, that is our local GB month, and at SMGS. To start with the panel discussion, I will request Smita Bush ma'am. Ma'am, being in charge of the child health division at the ministry, and your involvement in the policy matters, decisions is of prior importance. I would like something of what are the major challenges and issues in the newborn health from national perspective, and what Government of India is planning to do in this direction. Over to you, ma'am.
Once again, I congratulate the team Jammu Kashmir for organizing this, and the theme, keeping the theme together, the maternal and neonatal newborn health MNH conclave. And discussions were taking place. But something very, very notable, something we talked about maternal health, neonatal health, but we missed a very vital area. Like it was maybe mentioned in some of the discussions, but it never came up. The stillborn. That is again a very, very important area. If we want to really improve our MNA services, that stillborn, we have to come with the stillborn. We have to see why this has happened, why this celebration did not come in the end of the motherhood. So that is why issues and challenges are many, many were discussed. I will briefly talk about the major policy, that is the India Newborn Action Plan. That plan is in place since 2014, and it has tried to comprehensively deal with neonatal health. Every newborn must survive. Every life has to be celebrated. So that is what is the essence of the policy, newborn policy. Because newborn health, we all who are here, who all are working here, we know newborn health is not a single someone's perspective. It is everyone's business. It has to begin even before conception. Before the young girl gets pregnant or married and pregnant, it starts from there. Their health, their anemia level, their nutrition level, then their bearing pregnancy at an early age. So all this has bearing on newborn health. So it begins before conception. Then that is the concept of our INA program, that it has to start in preconception stage. During conception, that is the most important period. That pregnancy care, high-risk detection, high-risk management, as well as birth preparedness and birth planning. Where the delivery will occur at what point of time. So that is the main challenge, to beforehand to pre-plan the pregnancy delivery. And then comes the immediate intrapartum period. For neonatal health, for mother's health, that is the most critical period, the 24 hours around delivery. That is the most important period. Statistics say 46% of maternal death occur there, 40% of neonatal death, 40% of stillborn. So that management of intrapartum care. So again, INAP has started 2014 and we are midway. So where we have reached, because intrapartum care, the major issue is the attendance by stillborn, which we have achieved the target. Then the emergency EMOC capability. That EMOC capability has to be there at the delivery point, and the continuous monitoring of the pregnancy. So these are very important issues that we must have at delivery points: continuous monitoring for the fetal health. In the antenatal period also, we always say about high-risk mothers. But even if the mother is not high-risk, there can be risk to the fetus. So that monitoring has to happen. That monitoring, IUCR monitoring, international quality service should include all this antenatal care. Then the third pillar, the immediate newborn care, the resuscitation, the necessary giving the prevention of hypothermia. So all these are immediate care, which is again a third pillar of INAP. Coming towards the fourth pillar, that is essential newborn care, which every newborn must receive. That is, to name a few, the breastfeeding, the immediate skin to skin, that is there, the immunization, the birth doses. So again, that is the immediate, essential newborn care. So all these pillars have to be improved. That is the policy of, the vision of INAP. Then coming, the fifth pillar, that is the care of sick and small newborns. So again, we have achieved a lot. You have also stated that lot of facilities, essential survival, what is there for the newborns, immediate care, the community-based care, following up the newborn essential discharges, then finally screening of the newborns for treatment for birth defects, for following them up for delays through our very well established RPSC program. So our plan is very comprehensive, and we have achieved our 2014 midterm targets. We have achieved most of them, majority of them, but there are gaps remaining. Many states that present the recent 2019 SRS have given us hope that many states are almost there. Many have actually reached that goal. Many are almost there. Many is likely to achieve it, barring some 6-7 states. But this, what we are trying to do in our INAP document, there is a commitment for midterm review. So we have started with the midterm review. Yesterday it was talked about this midterm review, what we are planning to see where we have reached, what are the gaps left, and also going into the district level. Because even in the developed states, even in the states which have achieved a great average, but there are districts which are falling short. There are districts, 1 lakh paper said that almost 50% of our districts will not be able to reach our INAP goal as well as SDG goal. So we have to now get into the district level of planning, and that is the policy now. In the midterm review, what we are doing, we are looking into all the areas, all these 6 pillars, as well as we have added some other pillars, like subgroups we have created for urban health. For what about urban newborns? They are not being, was not being addressed through the present plan. Then private sector engagements. So all this, have come up. The groups have submitted their recommendation, as well as we have developed a bottleneck analysis. That tool was there in 2014 also, but now we have modified it and we have added many things to it. So with those tools, we have selected 4 states all over the country from the 4 corners, and Jammu Kashmir is one of them. UP is there, Telangana is there, and Meghalaya is there. So these 4 states, 2 districts each we have selected. In Jammu Kashmir it is Kupwara and Poonch. So where we do this analysis, bottleneck analysis, as well as the subgroup expert recommendations are there. So on basis of that, the action plan will be developed in these districts, and they will be finalized, and after that these plans will be emulated in all other districts of the states as well as in the country. So that is the plan, that is the policy, how we are working towards newborn health. INAP, we know it is based on many things, that is convergence, collaboration, accountability. All these are in the original document, also the initial document, but we want to build upon that, and that is, if we look at what are the causes, the major causes that has come in SRS, latest report, neonatal mortality, major causes has come, 46% is preterm and low birth weight. That is the major chunk. Then comes the birth dysphagia part, that is around 14%. Then comes the septicemia part and other causes of which congenital anomalies are there. So when we analyze these causes, mortality, neonatal mortality causes, we see a large area is beyond the realm of the neonatology. It comes before that. It is in the antenatal period where preterms are being born, where small chordates are being born, where congenital anomalies are there. So we have to work, that convergence mode. We Yesterday, maternal health death was discussed, neonatal death was discussed, but the main, where it coincides, that still part, if we analyze them, then we know where our facilities are lacking in newborn, immediate newborn care, and where our antenatal checkups have failed, so that the baby would not survive with the delivery point. So, and it is interchangeable, neonatal days, and you all are working, neonatal days, stillbirth, perinatal stillbirths, they are all same actually. They come, something has happened 1 hour before, so they are born alive, something, if it happens few minutes or 1 hour back, delay, then a stillbirth, child is born. So, we have to take that perinatal together, we have to have convergence with our obstetric counterparts, we have to combine our antenatal, perinatal and postnatal services. Otherwise, in isolation, we cannot address neonatal health. It cannot be addressed. So that is first thing I think is very important. Second issue and second challenge is about quality. Recently, in the line of Laksha, we have come out with quality certification of our units, that is our SNCU, NPSU, higher units, pediatric units. So all NICUs, pediatric units. So all these have come under the certification process. So I would request that all the states take up this very seriously as Laksha is happening, because Laksha is important, labor room quality is very important for neonatal health, no doubt of it. The labor room practices, the labor room protocols, the labor room supplies, labor room, HR, everything is important. Similarly, all our SNCU, NPSUs and pediatric units must have the proper standards, benchmarks, which is the ENQA standard. So that is, quality is very important. Our coverage, our SNCUs have grown, but when we go there, when we visit, that lot of need for quality improvement, HR capacity improvement. So that all these things are very, very important for neonatal survival. And I must mention one of the issues which is again coming out because of so many SNCUs have come out, that over treatment. That is also happening. Neonates who are not needing admission, they are being admitted. And that is what it is giving rise to, that they are being separated from their mother. So that is a major harm we can do to a newborn. So that again we have to be very conscious about it. So my formula is QR, Subha morning only I thought of. Quality is, we have to be very careful. Then we have to be, R is the referral, which was very, very well discussed yesterday, that where the neonate needs to be referred from one unit to other, the necessary, we have must have all the stabilization in place, plus as well as the transport, the facilities, the information to the higher facility, then coming back referral, all these things are very important. For S, I must say, surveillance. Surveillance, we know this is not a topic this time, but again, MTSR, like MTSR, child death, newborn death, this is a very important area. MPCDSR software has been launched, so we must count all our stillbirths, we must count all our neonatal deaths in a perinatal death surveillance, so that we don't miss out the stillbirths or the early neonatal deaths. And of course, beyond that, so that surveillance is very important. Then team is nothing. We all know, we are all engaged in it. Training, capacity building. So convergence with our antenatal services and all this, which are happening. I'm not saying they are not happening, because we are on the right course, we are on the right track, but we have to expedite it. We have to give more focus to our newborns and stillborns, and we must
you, Susmita ma'am. We got insight into the program, and Ashas have been a very pivotal in child health department, I think, because they have been the main lead, rather the link between the community and the medical profession. With permission, ma'am, I request Dr. Samia Rashid, ma'am, to kindly go ahead with the discussion, ma'am. Being the head of the premier institute in our state, what challenges as an administrator you are facing in newborn health, and what can be done to strengthen health system as a way to improve life-saving childbirth care practices? Over to you, ma'am.
Very good morning to all of you, and I congratulate the department of NHM, especially J&K Brown, for conducting this program so well. And it is an opportunity for me to give you as an administrator that we have to strengthen the nursery care, particularly around the time of birth and the first week of life, as most people born and die in the first week of life. And to improve the quality of maternal and newborn care from pregnancy to entire postnatal period, including strengthening of midwifery. And we should expand the quality services for small and sick newborns, including strengthening of neonatal nursing. We should lay emphasis on strengthening midwifery and strengthening neonatal nursing, because it's very important to have a proper antenatal checkup of the lady and follow her through the pregnancy and in the postpartum period. Give her proper nursing, then there will be no loss of life at that time. And we should reduce inequities in accordance with the rules of clinical health coverage, including addressing the needs of newborn in humanitarian and fragile settings. And we should promote engagement and empower mother, families and communities to participate and demand quality newborn care. And we should strengthen engagement, program planning and accountability to count every newborn and stillbirth. We have set up these SMEs, but what is important and what is challenging for us is to keep them running, because when we have the infrastructure, but for running the infrastructure we need consumables, like tubings of the ventilator, the medicines, other consumables, and we should have proper NHMs and here, and we have had good facilities and a lot of improvement. Our infant mortality rate is decreased, our maternal mortality rate is decreased. There's improvement in giving care to the patients, and especially newborns. We are doing a commendable job, especially our Department of Pediatrics and this obstetrics. They are doing a commendable job. We have come up to the level where we have decreased infant mortality instead of increase. But what is important is to run these SMCs. For that, we need consumables, and NHM should be supporting and giving it to us. Because, we have the ventilators, but the tubings have to be changed every other day, and each tubing costs a few thousand rupees, and that it's not there, there's no point of having a ventilator. And NHM has been kind enough to give us the grants, but we should be able to maintain that system. I think what is key practices and interventions which can dramatically increase the newborn chance of survival are essential newborn care, just mentioned, which is very important for all babies, which include a clean delivery system and a ventilated skin to skin contact with the mother after birth, combined newborn care, immediate and exclusive breastfeeding, resuscitation at birth, and for non-breastfeeding newborns. And kangaroo mother care, we have already established like MCH, Virginia Hospital, and it is a tool, it has proved a big intervention where there is continuous skin-to-skin contact between the mother and the child, and exclusive breastfeeding and early discharge windows. And it is better to identify and timely initiation of avoid antibiotics because there is an infection which is part of the child, and once they are dismantled, there's a chance that the child will survive.
your side, I would like that most of the cases of newborn deaths can be prevented with existing cost-effective interventions. However, ensuring universal access and utilization of key interventions remains a challenge. What is your opinion? What is, in your opinion, needs to be improved in order to improve the survival of newborns, as neonatal deaths contribute a major chunk of infant mortality? Over to you.
Thank you, Dr. Misbah, and good morning, everyone. I am very happy to be here after a hiatus of about 5 years, and I must congratulate the MD NHM, Chaudhry Mohammad Yasin ji, along with his wonderful team for doing the excellent work which is now visible in terms of the reduction in mortality that has been proven and shown. So I must say that J&K is a shining example of coordinated efforts in the public health arena, culminating in improved survival and impressive decline in the neonatal mortality rate. Now, asking about how do we go about managing newborns so that there are minimal or no deaths and there is survival, which is not just survival but intact survival. So I will touch upon 2-3 aspects. The first one is care around birth, which is very important, and everybody has been talking about that, including our ma'am, Dr. Sumita Ghosh, and Dr. Saima, who just spoke about it. So care around birth is one of the most important aspects of newborn survival. We all know that 75% of IMR is NMR, and in the first week, 40% of deaths are taken. So also 55% of under 5 mortality is newborn mortality. So how do we go about tackling that? We all know that there are 3 reasons or 3 main causes of death: perinatal asphyxia, prematurity, low birth weight, and sepsis. So all the deaths of perinatal asphyxia will occur within the first week. Those who have to die. Those who survive is fine, but those who will die within the first week, and majority or 50% within the first week. So the major chunk of death is related to perinatal asphyxia. The other one is prematurity. 75% of deaths which can be attributed to prematurity are occurring within the first week. And 50% of all infection-related deaths are occurring within the first week. So this chunk has to be addressed, and how do we address that? First and foremost is a clean birth which should occur in the labor room or in the operation theatre. Asepsis has to be maintained thoroughly so that the babies are not exposed to infective environment, and we must all take it as all our healthcare establishment can be potentially contaminated and infected. So we need to ensure that asepsis is being taken care wherever birth is occurring. The second most important thing is if the baby is born and is crying, irrespective of his gestation, even if it is a 32-weeker, the baby must receive skin-to-skin care, or the baby must be placed on mother's chest and abdomen for routine care. Delay the umbilical cord clamping and cutting by 60 seconds or 1 minute. And the baby should remain on the mother's chest and abdomen for 1 complete hour, 60 minutes. There is no hurry of weighing the baby, giving vitamin K or giving the vaccinations or putting a label or the tag of baby of so and so. The baby is not going to get mixed up. They might get mixed up if you put them under a warmer. 2 or 3 of them were born at the same time. But they will not get mixed up if they are on the mother's chest. So this is the most important aspect at around birth. And then not to forget the next 4 to 6 hours after birth. The first breastfeed should be initiated on the labor table within that first 60 minutes. If the baby advances towards the breast, very good. If not, the healthcare provider has to ensure that he advances the baby towards the breast and the baby gets his first food. This will initiate the feeding early, and that is what is required. That is one of our indicators, early initiation of breastfeeding. So this will initiate breastfeeding early, and it has myriads of advantages. This is not the forum to talk about that, but this must be ensured. It is something similar to a new building which has all the electricity wirings in place, all the bulbs, tube lights in place, but the switch has to be switched on for the lights to come on. Similarly, the maternal body is all ready to lactate. But what is the switch? Switch is the baby touching the nipple or sucking the nipple. The longer it is delayed, the more difficulty in breastfeeding. So it must be started immediately. The first breastfeed should be on the labor table in front of our obstetric colleagues when the baby has been put to the breast. Thereafter, essential newborn care, which has been alluded to by ma'am as well as Saima ma'am, that we need to ensure two things that are prevented. Prevent hypothermia, prevent infection. Two things that need to be ensured. Ensure baby is breathing well. Ensure that the baby is feeding at the breast, is receiving the nutrition, is receiving breastfeeding. So this is around the birth that needs to be ensured, and for this we have, and resuscitation of course is one of the most important things to prevent perinatal dysphagia. For that, the new NSSK guidelines, the manual is ready, and this is now tailored to the fact that we are going to train the people who are actually attending birth. We have had a dichotomy where we were training people in newborn resuscitation who were actually not handling the newborn at all. So we had numbers like we have trained X number of people or X thousands of people who are trained in neonatal resuscitation, but they were not attending births. So who are to be trained? It is the targeted people who are attending births. ANS, nurses, whoever is attending the birth, they need to be trained in NSSK. And the current NSSK is no didactic lectures, no PowerPoint presentation, no book reading. It is only hands-on with one facilitator and 6 participants and ample of mannequins and other supplies that need to be ensured to have adequate resuscitation skills. The trainer himself or herself must be able to provide target mass, ensure that he does it for that time that is required, and we can see the baby's chest swelling. If we don't have that, then the trainer is only speaking things out and we are not even making the participants demonstrate back to us. So that is one aspect, care around birth. The second aspect is care within the unit, whether it is NBSU or SNCU. Earlier we had only the SNCUs, so there was a gap in between. We had SNCU, we had some NBCCs established, but NBSUs, although physically established, the infrastructure was there, but they were not really functional. And I'm not sure if they are functional as of now also. So with the new stabilization guidelines that have come in the NBSU module that has been prepared, with 10 instructional videos, they are looking after every aspect that needs to be taught to an NBSU person. Again, we have to realize that at SNCU we have pediatricians, we have nurses and some medical officers. But at the NBSU we will have 1 medical officer and 4 nurses. So the level of training has to be very, very clear and in very simple terms. So the NBSU current module addresses that, and that is over 2.5-3 days, and it takes care of reporting, it takes care of jotting down, it takes care of putting it on the portal. So all those aspects have been looked into that. So with this continuum of care, right from NBCC to NBSU to SSU and to tertiary care centers, we can ensure that we have better survival of babies, and this survival is exact survival. I would like to touch upon one aspect, and that is LSCS that was discussed yesterday. The high rate of LSCS. Please understand, all our obstetric colleagues and pediatric colleagues, that if a baby is born by cesarean section, he already has 1 odd against him. The baby, as far as possible, should be born vaginally. Why? Because his microbiome that he gets from his mother through the vaginal birth. So he gets seeding with healthy bacteria, healthy organisms throughout his gut, which is going to determine his immunity for the rest of his life. It's not just during neonatal period. So we must try and make an effort that the babies are born vaginally as far as possible. When we say we have reason for cesarean in terms of family pressure, some political pressure, or some other pressure, we as the care provider should be convinced that this mother can deliver normally and should be allowed to deliver normally. We have to invest time and effort into that. With passing time, our postgraduates will learn how to do cesareans, but they may not be very adept at learning how to monitor a normal delivery or a vaginal birth. So please, it is in the best interest of the maternal health, but more so in the interest of the baby. The second thing that needs to be done for the baby, one is ensure vaginal birth as far as possible. The second thing that needs to be done is ensure that the enteral feeding is started as soon as possible 2 hours of birth, not later than that. And I'm talking about babies who are in the SSU, NBSU, NIC. I'm not talking about healthy babies in the postnatal ward. They, of course, have to be breastfed right away. But even these babies must receive mother's milk enteral feeding from the start. So if we do that, we are populating the same microbiomes, the same good organisms, which are going to take care of the baby, which will fight his infection and do a lot more very good things. The third thing is, if not required, please do not administer antibiotics to the baby. These three things are actually clinical. The sure shot formula for ensuring that the baby does not survive or survive very poorly is let him be born by cesarean section, do not feed him, keep him in pure, give IV fluids, and give him antibiotics. It's a decoction which is detrimental for the baby. So we must try to do the other things that we just spoke about. I think that's all that I have. Thank you. And if there's more, then I can add.
Thank you, ma'am. Ma'am, basically, we got an idea that the main task is actually the training of the staff, rather the refreshment of the training of the staff. So, with permission, I would like Dr. Jan. Sir, you have already been actively contributing in drafting the IMR action plan for J&K, and J&K recently published SRS and has seen a decline of 3 points. But the rate of IMR decline is slow, and there is still a long path to travel in order to reach a single-digit IMR. In your opinion, how can we address the barriers that are impending and the impending acceleration of decline in the mortality? Over to you.
Assalamu alaikum. Good morning, everybody. First of all, I'd like to thank the NHM Department J&K for organizing this session. And I personally thank on behalf of GM Srinagar to NHM because of their support we upgraded our NICUs in 2012. And whatever little we achieved in declining neonatal mortality or mortality is because of a lot of support that we have brought. Now, having said that, I just wanted to give you an idea about the ground problems that we have here in Kashmir. A little bit about overall newborn status. India alone, almost 25 newborns are delivered every year. Out of them, 1/3 are low birth weight. So you have to understand, we are a country where 8 million low birth weight babies are born. And we've already heard about the panelists saying how much premature babies are more prone to die. Every year we lose around 750,000 units in India, and we contribute to 25% of global neonatal mortality. Imagine a newborn, it's just a shielding. Life is yet to begin. If we lose it, it's loss of your whole life. And if there's a minor stress or minor trauma or minor insult to a newborn, you have a handicap or a disability for the whole of his life. 74%, we know the IMR majority of 75%, the neonatal mortality. Out of that, 74% babies die in the first week of life. And out of first week deaths, 40% die in the first 24 hours. So you can imagine the period, first 24 hours, how crucial it is for us. Causes, all of us know the major chunk of causes of newborn deaths, preterm low birth weight, or sepsis, infections, or asphyxia, or hypothermia. If you collectively see them, they make around 90% of neonatal deaths. But what I want to emphasize is that these are preventable newborn deaths. We can prevent these deaths. There still are gaps between rural and urban care. There are still gaps between rich and poor, the amount of care they get. And there is still gender bias in our society. We need to address that. 3 points before I come to the actual topic of our interventions. I just wanted to highlight 3 things. One is the maternal age at delivery. Second is the level of education that the mother has. And the third is the nutrition status of the mother. They all 3 have a bearing on newborn health. You see, in our country, still 20% of deliveries are happening in women less than 20 years of age. It is said that if we can postpone delivery beyond 20 years, we can reduce neonatal mortality by around 9%. If you have an educated mother, she has a better health-seeking behavior. Her behavior is more towards preventive aspects. So our girl child education is still less. We may have in our state, in UT, I think it's around 77% as per the NFS's 5 data. We still need to work on that to have a better education for our girl child. Nutrition. We all know a healthy mother gives birth to a healthy baby. If you have a manless mother, you're going to have a manless or an unhealthy baby. Our nutritional care of mother should not start in pregnancy, it has to start in the infancy to adolescence. That's the girl child. We have to focus on health of a girl child. Nutrition of a girl child, including proper immunization. Now, having said that, we come to the antenatal clinics. Now, our intervention, what we can do to prevent newborn disease or disabilities or to prevent newborn death. There are 2 major things. We have already discussed that. One is antenatal checkups. How many percentage of our pregnant ladies have come to our antenatal clinic. Second is how many of them are had institutional deliveries. Both are going to impact our newborn survival. You see, our antenatal checkups are very important. If a mother is in a regular antenatal checkup, we can take care of her anemia. We discussed yesterday how big a problem anemia is. Almost 70% of our female folks are anemic. We can take care of her hypertension. We can take care of her diabetes. We can take care of her infections. We can take care of her nutrition. I have said earlier, I want to repeat it. We need to have nutritional counselors in our antenatal clinics. Because they are the ones who not only build up the guide the mother regarding her nutrition, but they also prepare her for breastfeeding. They also explain to her the advantage of breastfeeding to the baby as well as to the mother. And they look at minor problems, sometimes they have inverted nipples or something else. This can be taken care of. So that at the time of birth, a mother is ready to breastfeed. And she knows the advantage of breastfeeding. Then the antenatal visits help us identify, not only monitor the growth of the baby, but also the well-being of the baby. You see, if there's a high risk pregnancy, we need a referral. But what's more important is a timely referral. When you get referrals, as our gynecologists were saying, if they get late, they cannot do much. Timely referral is very important. And that's possible when you have antenatal, regular antenatal checkups. Just if imagine a baby mother has gone to a premature labor, just a dose of steroid before referral. It's going to do a wonderful change for the baby. A lady who has a premature rupture of membranes, just a shot of antibiotic, it might save the life of that baby. Minor interventions, major benefits. We have to focus on that. So antenatal visits, we have to make it. You know, Lakshadweep has 99.8% of antenatal clinical visits. We lag behind. We have to improve. So is institutional deliveries. Now why we are focusing on institutional deliveries? Because we know we have facilities in institutions. We have trained manpower. Wherever we have district, we have to give regular trainings and frequent trainings. Improve the skills of our manpower who are working in the labor. The resistant equipment, all have to be there. So institutional deliveries and regular antenatal, we need to focus on that. A baby, majority of time, problems happen within the first 24 hours. If we can have manpower, and to skilled manpower, nothing more. You see, we have developed newborn care corners, so wonderful. We have NBS, newborn steps units, great. But the problem is that these newborn steps were developed, we have one medical officer and 4 nurses. They don't run 24/7, they are 24 hours. So they are a failure as of now. They are supposed to take care of babies, low birth weight babies, beyond 1800 grams with no complications. Yes, they can be taken care of in NBSU. Jaundice can be taken care of via charter vaccines. Sepsis can be treated in these NBSUs. But they are not functioning because we don't have manpower. We need to develop a project and develop it completely. Second thing is that we have a lot of load shedding, particularly in winter months, and hypothermia is a killer here. So these, wherever block level we have NBCC and NBSU, we should have a power backup. We need to have a generator facility so that these run 24/7. The question is that we were talking yesterday about referrals and referrals. Why so many referrals? Do we need so many referrals? You see, I work into a center. What I get? Jaundice referred to us, bronchopneumonia referred to us, sepsis referred to us, convulsions referred to us, respiratory distress referred to us. A child is referred for respiratory distress from a place around 50 or 100 kilometers away. By the time he reaches to us, he dies of hypothermia. He doesn't die of a respiratory problem. He dies of hypothermia en route. So, these referrals from far-flung areas, they also add to our mood. Yesterday we had a good discussion on pre-referral, stabilizing and then proper referral. Probably at district level we should have transport incubators and ventilators. At least at district level, if not at sub-district levels. But my point is different. Why can't we manage them there? It may not be possible to have an ICU everywhere, but at least one in the north and one in the south. So like we have this MCH Conclave, we can have MCH centers. Now we have medical college and we have luckily under ERCP2, we have no ICUs also. So why can't we get the manpower to have a good neonatal and obstetric backup there? In this, you develop two sectors, one in north, one in south. And flood them with, we have good number of obstetricians, neonatologists, or pediatricians, anesthetists, a good blood bank. And ICU already, the infrastructure is there now. Why can't we have these people being managed there? Because long reference from far distances, they are adding to our mortality. If we have to reduce our mortality, we have to ensure that we build up our welfare. Then we did, ma'am did talk about KMC. It's a small intervention, but it's a major impact. This is not a costly intervention. You just need to explain how KMC is to be done to low birth rate babies. It's doing sea of good change. We have done it in the hospital. It prevents infections for the baby, promotes breastfeeding, prevents apneas and prematurity, and then they have developing bond between mother and baby. So many benefits that we have by KMC. I think it should be encouraged at the home-based level also. We have a essential newborn kits already discussed, but we have a home-based newborn care also. There's a program called HBNC, where Asha goes in and takes a look at home also. In institutional deliveries, there are 6 visits up to 42 days. In non-institutional home deliveries, there are 7 visits. She teaches them about the clean habits of how to handle the babies, to prevent infection. She teaches them about how to prevent hypothermia. She is playing a good role in promoting breastfeeding, promoting immunization. And she has the responsibility of picking up warning signs so that babies who are unwell or sick, they can be referred immediately. But then this is not easy. So much so on Ashas, everything on Ashas. I believe they need to be trained frequently because these vital, signs and symptoms she has to pick up. It takes a lot of expertise and experience. They need to be trained repeatedly and frequently to have better results. Lastly, yesterday we had a discussion on cesarean section. I wanted to comment, but there was a very hard debate and it was quite. You see, sitting and compare right away with Denmark and USA and England, I don't think we should do. We have to see our situation, what we are doing. I have had a good association, our obstetricians here, leading obstetricians of duty for more than 3 decades. And I have had the opportunity of working abroad also. I worked abroad in a center where there were 8, it was a Bedford center where there were 8 to 10 deliveries a day. It had a wonderful NICU as well as an ICU for adults. The place was where there were 8 to 10 deliveries, loaded with obstetricians and pediatricians and anesthetists and nurses. And there was such a wonderful monitoring. CTC was being done regularly in fetal heart and everything was being monitored. Whenever there was an actual indication, they would do, otherwise they would not do. So they could maintain a rate of 15% or 20%. In our sector, if you see our guy obstetric department, you have 120 to 150 deliveries every day. And I have seen, when the gynae takes around in the labor room, she knows that by the time she finishes around, there are 10 or 12 cesareans already decided. Then she has to finish those 12 cesareans to come back for her. It's another 10 hours. Even if there is minor tachycardia, she shifts with it. She knows by the time she comes back, either there will be IUD or there will be a 6 To prevent that, she has no other option. This is have seen in our obstetric department. A mother declared fetal distress. She's waiting in queue in the theatre on a trolley. Her number is 7. Baby has fetal distress. But her number, because 2 theatres working around the clock, they are busy. There are other people with distress getting ahead. This is the ground situation. So comparatively is not possible. I agree with Dr. Salim Rahman what he said. The results matter. And our results are better. Our infant mortality and neonatal mortality has gone down because of decisions taken by our obstetricians. Unless we share this load, if we strengthen the pelvic, if there is lesser load, perhaps we can monitor these deliveries better. And that sensitivity will go down. As Dr. Sushma said, as pediatricians, we always like to have normal deliveries. Our babies are far better off if they are normal deliveries. You know, I'm scared. One is they go into infection. Second is they develop respiratory distress. Those who want to see transient epilepsy, we see so often, they have to be separated from their mothers and go to hospital now. You see? We always welcome normal deliveries, but the ground realities need to be addressed. And if benefits are built up and if benefits take a load and is shared by multiple places, perhaps yes, our senior secretary will go down. Thank you, sir.
Thank you, sir. Before we go ahead with the discussion, I would request everybody to tweet and retweet on MCH Conclave Day-2. Thank you. Now I invite Dr. Bashir Ahmed, who is head neonatology SKIMS Surra. Sir, as far as causes of neonatal deaths are concerned, prematurity and low birth weight are main contributors of neonatal deaths. You being head of the neonatology department at one of our premier institutes, what can be done holistically to prevent such cases? And what role does community have in improving newborn and childhood? Over to you, sir.
Sure. Very good morning to all of you. I think the major chunk of the preventive neonatology has been already touched by the learned experts. I fully agree with what Sumita or what my friend Muzaffar said, that the major killers, and all we know, the major killers of our newborns are low birth weight, prematurity, infection, and unregulated fertility, very short pregnancy interval. Well, rightly said that things may not be as easy in practice as they are in theory. Like Muzaffar talked about maternal malnutrition contributing to low birth weight. In a heterogeneous country like India, where you have wide gaps in incomes, where you have wide gaps in education, where you have wide gaps in care, delivering nutrition services is a difficult task. Maternal, every pregnancy has a burden. It entails pregnancy, normal pregnancy entails a weight gain of 8 to 10 kgs, which in caloric terms translates to about 60,000 calories that you need to feed to the mother to have a normal weight baby. With subsistence of say $2 to $3 per day in poor households, how do you, and the present inflation trend in the country, the food prices are skyrocketing. So how do you ensure this much of nutrition is very difficult. Then there is a problem in nutrition that majority of our, say, rural women, are engaged in hard farm work, and in urban slums you have women working in construction workers are working in factories. So that entails a further additional caloric burden on their bodies. And how do probably, this comes in the realm of poverty alleviation and would be a socio-economic factor than a medical factor. But how to address this, I would say probably like we have a nutritional supplementation, a midday meal program for children, I think we have to come up with a midday meal program for pregnant women also. I mean, only iron and folic acid would not do. We have to have a nationwide program that once a woman becomes pregnant, she has to be ensured with some food coupon or whatever system the government feels fit to ensure that she gets the required caloric and protein input that it needs to sustain a healthy pregnancy. Then I would like to echo what Madam Sunita said, that this is in a vast expanse. A huge country like India, probably all of it may not be with one program, and probably what we have done is having Ashas, and they are doing a wonderful job. And this Asha basically has come from the wonderful couple, Abhay Bang and Rani Bang. Probably we need many bangs in this country, in every district. We need a bang, a Gadchiroli model to address the neonatal. And another important point that I want to address about reducing mortality and preventing future morbidity is antibiotic use. We have studies coming from whole of the world that neonatal as well as early infant antibiotic use, especially the broad spectrum antibiotic use, I mean, it does more harm than good. There are studies coming about that the disturbed microbiome leads to later obesity, and it's a well-known fact that low birth weight babies in later life are prone to develop we have an epidemic of non-communicable disease because of early life nutritional disturbances and later life nutritional excess. That's going to lead to an epidemic of non-communicable disease, which we are witnessing now. So neonatal practices have to be tailored to the current evidence. And what Dr. Sunita rightly said, that we have to ensure that we do no harm. Then prevention of infection, again, it's all theoretical, practically very difficult. How you prevent infection in a neonatal care unit? I am running a neonatal care unit, Muzaffar is running a neonatal care unit, Mushtaq is running a neonatal care unit, Ghulam Rasool is running a neonatal care unit. Are our neonatal care units established as per the norms prescribed? I would say WHO is a far cry. I would say Indian Academy of Pediatrics. Are our neonatal units established as per the norms? Probably not. The space that's to be between the two open care units, I mean, is not that space that would be conducive to ensuring asepsis. The space is not there. Then the nursing is a very important issue. Say 3 to 4 ICU beds should have at least one nurse, and as per established norms, a ventilated baby should have one nurse per bed. But that's not the norms are nowhere near the practical scenarios altogether different. And then how many of us are also probably responsible for ensuring asepsis, in the sense that do we do a religious hand wash? How many of nursing care units have hand wash facilities, and how many of the units religiously follow? There's a huge question mark on that also. And third thing that all of the panelists impressed upon was probably breastfeeding. Breastfeeding is a wonderful saver. Me and Mushtaq have done a robust work on this a decade back, and that was under the patronage of UNICEF, assisted by Breastfeeding Promotion Network of India. Again, it's a wonderful vaccine, wonderful antibiotic, and wonderful nutritional support. But sorry to say that we are lagging behind. Exclusive breastfeeding rate of 40 to 60% is not a healthy sign. And the responsibility somewhere lies with us, with the healthcare providers, and somewhere the industrial promotion works on us. Somewhere we are at fault. Thank you, and God bless.
Thank you, Dr. Bashir sir. And now, to continue with the discussion, I would request Ma'am Dr. Sushmita Ghosh to throw some more light on midterm review of INAP and what are the challenges you think that there are in our country, and how newborn survival and midterm review help in reducing the newborn mortality.
I did not anticipate the second question, so I somehow touched upon it. The midterm review is to see when we have reached. There was a commitment when the original plan that there will be a midterm review. So 2020 we started, but because of COVID pandemic, something did not proceed that well as per plan. So last year onwards, we have, as I said, midterm review for finding the gaps have started. Though we have received, we have reached, we have arrived the midterm goals. We have, the coverage targets out of 3 goals. We have almost, we have coverage 3 totally. That every district will be at least 80% districts will be having SNC. Coverage, other coverages are there. This 4X coverage slightly falling short. We have to build it up. But the issue here, what was the main vision was there? That to have a comprehensive all 6 pillars, they should be complete. And they should, the principle of convergence, equity, they should all be fulfilled. So that gaps are there. So that is the, this time we are trying to find that gaps, and then we have to plan district level. Because overall, many states have done very well, but even in the, even in Kerala, there are districts where which is not liking together find out what the statistics of the cancer, and that model then similarly situation distribution given, and that is the plan that the remaining time what we have in 2030 we must achieve whatever was originally planned and more, because situations are different. The setbacks are coming because of something such big as pandemic like COVID. A lot of new programs have come out. So how to utilize those programs, how to utilize our assisted programs, how to utilize. So all this should be a part of this planning, and that is our idea for this midterm idea, so that we reach as a state, we reach the targets, and as nationally we reach the target, and district-wise also as much as possible, because present statistics and the decline rate, we have shown that around 50% so we want to reduce that. Yeah. But this recent QS services, one is on modeling which have come, and there's this which has given us because of MMR also, MMR also, as they have shown that we are in a way
Thank you, ma'am. From your discussion, I have come to the conclusion that there is a lot of way ahead, and we have to strive for the goal to reach to the single digit. Ma'am,
I think maternal nutrition you pointed out. WCT has programs for maternal nutrition also. Maybe we have suffered because of COVID, as well as they have been 6 years, 0 to 6 years, and plans.
Gender inequality in nutrition. Yes. That gender inequality in nutrition has to be addressed. You have women feeding on left works, probably either because of their own choice or in the family compulsion, but then you have women feeding on left works, you cannot have nutrition. And over some, there's another problem in maternal malnutrition, that's maternal nutrition, that's that many of the women have poor dinner. Many of the women in urban slums have poor dinner because of the lack of facility of how to ease themselves in the morning in a dignified way. So those issues have to be addressed on the social economic platform.
thank you, sir. Right, you are absolutely right, sir. Basically, it's the interconvergence with all departments like social welfare, education department, as well as child health is concerned. They have to be taken on board. And as CS sir yesterday also said that anemia mukbar, if we take that condition as a benchmark, we have to take other departments on board so that they can be implemented. Thank you, sir.
Adding to you, sir, I would say inequity, gender inequity is also a big contributor to our gender mortality, because girl children are taken. So that is another angle we have to analyze our gender mortality, because if their intensity is not there from the family, then of course the new mortality figures will be high. So that kind of disintegrated analysis is also very, very, very pertinent for states on a district.
Thank you, ma'am. Now going ahead, ma'am, I would request Dr. Sushma to deliberate on some main questions. That is, operational guidelines for facility-based work care is now almost more than a decade. Can you take us through your journey, the challenges, and the way forward? What in your opinion should be the focus of facility-based work care in time? More to you.
So the journey of facility-based newborn care actually started 15 years back, 2007. But for J&K, this is exactly a decade old. So in 2012, June, 1st to 3rd June, was the time we were here because of some newborn deaths, and the Honorable Health Minister then, Shri Ghulam Nabi Azad ji, wanted a security department to have a look and see what needs to be done. Anyway, so that's where the thing started. And after we had a presentation with the Principal Secretary Health and the MD NHM then, it was decided that the state would want to establish SSUs and start the capacity building of the doctors and nurses for that. And I must compliment the then state and now UP, whatever you may name it, that they have gone in a very meticulous manner in terms of organizing this whole thing. The complete commitment of the state was there. There was bureaucratic, there was political will into it, and the NHM worked fantastically coordinated manner with a lot of dedication to have these trainings being done very immaculately. By which I mean the nominations were on time, people were deputed, they were there for the trainings. There was never a time when they were less than what they should be, or people didn't turn up for the training. And then coordinating their observership in another state, coming to Delhi, all their payments on time, their nominations on time. So state has done a commendable work, and I think we see a lot of result of what has been put in the whole decade of the last decade, and we are able to see in terms of the neonatal mortality that is reduced. And the way how we look at it from now onwards after the decade is that we're all aware. We don't need to do any more advocacy. Everybody knows that yes, newborn is the prime focus and we need to look at the newborn. Of course, along with the mother, we need to look at the baby. So we don't need to do that groundwork. Then infrastructure is already there. We have the SSUs, LBSUs, all these are established. So infrastructure is already there. What is required? Even equipment, all the specifications have been done at the NHRC level, and all the equipment that needs to be bought and the number of equipment, all that has been sorted. So what needs to be done now is we need to have equitable distribution of 3 M's. The manpower, the machines, and the money. So wherever it is required, we have a difficult area, probably we need to pay higher to the manpower. We need to train the manpower which has to be skilled and which has to be there at all these places, whether it is LBSU or SSU or even at the higher level like NICs. So the path from here, the low-hanging fruits have actually been plucked. The path from here becomes tougher. As we go higher up the hill, it becomes more tougher. So more expertise is required, more dedication is required, and of course there is no denying that we need adequate and skilled manpower that should be there. And the machines, even if they come once, as Madam very rightly alluded to, that machines are there, but the upkeep of those machines in terms of their annual maintenance contract, as well as the consumables that are required, the tubings, the filters, whatever, even for CPAP you need the interface, the humidifiers which malfunction sometimes, and they have a finite life. So all this needs to be now invested into, that we have the maintenance contracts for the equipment that have been bought, we have the manpower which is trained, and I must say that what we need further is resource center at the state level. So we need state resource centers. We may have 2 of them, one in the Jammu division, one in the Kashmir division, or the state has to decide. Maybe more than 1, more than 2. So they have to be there, and they have to now take up the responsibility of training and retraining the staff. The new recruited staff needs to be trained. The older ones also have to undergo some refresher. We cannot say that they were trained in 2012 or 2014 and they are continuing to do the work. So some kind of refresher that needs to be done. There has to be mentoring by our state resource centers for the various district level facilities that we have, and there has to be support or supervision that needs to be provided. So hand-holding is required. Whenever they run into some issues, some supplies are not there, or some issues. And then the last thing in this is look at your own data. So supposing this division at GMC is looking at some of the districts within the list. So 10 districts. So you have, let's say, very high asphyxia rates at Anantnag, which is what I had encountered when I had visited there. I'm sure it must have improved a lot by now. But let's say at one place you have a lot of asphyxia, at the other place you have a lot of sepsis. So when you're getting that data, you are looking at it as to why this is occurring there, what could be the cause, and what could be the remedial measure. So that is the kind of overall umbrella structure that we look at in terms of the state resource centers. And of course, the National Collaborative Center is there to support the state centers as much as they require. But I think now we have reached a place where the state can very well look after the training needs, the monitoring needs, mentoring needs, which needs to be done. So I think the way forward would be in this manner that our newborn health. So whatever our gains, we continue to capitalize on that and we don't kind of falter back. So these would be the next steps that we need to take. Thank you.
Thank you so much, ma'am. With this, I would like to invite Dr. Muzaffar Saab again. Basically, ma'am has already pointed out the major issues like sepsis, hypothermia, and timely referral also as you person for hospital. So we would like to know what are the main problems of prevention, how to improve that.
I think we discussed them already, but just want to highlight that, as ma'am has said that we have started this campaign, facility-based newborn care program, almost now 9 years old. And we are doing these trainings 4 days with 14 days of observership. And initially we had some issues regarding the distribution of our training. See, the doctors and nurses who were effortless, they would go and work in medicine department, surgical, they would not work in the neonatology sector, they would not work in the pediatric sector, they would not work in the labor room. So then we took up the issue with the Director of Health Services and with the Director of HM, then Director of HM. It was coordinated. Now we are having almost 80% who are working with the pediatric. Still there are some, it's not 100%, but we have come far ahead now. It was like 25-30% issue. So there was one issue that I wanted to discuss. Second thing is that I have discussed with Ma'am Ghosh also when she came to our hospital. They gave us money to start our ICUs. And it was a big boost for us. And we started our ICUs in 2013 when Ma'am had also come at that time. And we upgraded our care to a particular level. Now the problem is that we have to maintain that level of care. And I did request her that there has to be some kind of, you can't wash your hands off totally because there has to be some support. You have started the system. Now, what my problem today is that I need tubings for a ventilator. But the supplier is not supplying. He's saying that I need 1 crore is my liability, clear my liability. I need culture vials for the patients. The supplier is refusing to supply them. Saying, no, you clear your liability. So there has to be some way forward. I had discussed with Yasin sir also earlier regarding the issue, and he had promised me that they will do something about it. But we are really having difficulties in maintaining our. If our guard goes down, perhaps our mortality we are very important. And now that we have discussed so much about newborn care and all, you see, with this ECRP2, what you saw in the slides, fantastic. Most of the health centers now have ICUs with ventilators, with monitors. What you need now is manpower, skilled manpower. We need to focus on. Already have it placed there. Just needs a little bit more. Proper manpower in these centers will make them function 24/7, and that is certainly going to reduce our neonatal morbidity as well as mortality.
Thank you, sir. Thank you so much. With these comments, I would request all participants to, if they have any questions, they can before. Mike.
Anantnag, name was Dayton. I am from Anantnag. I am Dr. Mushtaq. I have been professor of neonatology in Scales for 25 years. Now I am heading the department of pediatrics at Anantnag, JMC Anantnag. I will talk administratively. Everything is being discussed in Srinagar, Jammu, Anantnag. We are catering a population of 25 lakh. We have Anantnag, we have Kulgam, we have Shupian, we have Pulwama, we have Pir Panchal, we have Banihal, we have Ramban. I joined in 1984 as pediatrician. There were 20 beds. After 35 years, there are 24 beds. 1 bed addition per decade. Please don't concentrate on Srinagar and Jammu only. Try to take care of us. We are JK03. JK01 is Srinagar, JK02 is Jammu, JK03 is Anantnag. When a dignitary has to come to Anantnag, there is no traffic jam. Because the whole traffic police is in action. Otherwise, we are in traffic jam for the whole day. Nobody takes care. We do not need multiple medical colleges everywhere, every district. We need multi-specialty hospitals in every place. I am demanding that we should build a 500-bedded multi-specialty hospital in Jalgaon. No patient will be referred to this place. I refer patients to SIGIMS, my parent institution. But GP1 falls on ways, the patient comes to GP1. Now, this facility also has to be taken away. This will go to Bemina now. They will have 500-bedded hospital there. They have JVC, they have SIGIMS, they have JLN, we have nothing. We have 24 beds. There is no central oxygen on Anantnag. After 4 o'clock, there is no X-ray. Not to talk of CT, other things in my hospital. How do I improve my child care? How do I improve my patient care? Take care of my, give me a hospital, multi-specialty medical college hospital in Jalgaon. No patient will cross Sangam Road. They will go to Jalgaon. They will not come there. One, we are being discriminated every killing on every front. We have been discriminated. NHM is doing wonderful job. I have 12 open cares in my department of pediatrics, Government Medical College, Anantnag, and unfortunately, I have only 14 nurses in the whole department. Will they take care of HDU, casualty, or nursing? We don't need manpower, we need manpower. We need nurses. We don't need multiple doctors. Doctors are getting more age now. We are just manufacturing doctors. 100, we have 13 medical colleges now. We don't need so many medical colleges. Kindly, NHM government concentrate on districts. Have everywhere a multi-specialty hospital. Give me a ventilator. I have 6 consultants. I don't want to refer a single baby here. No child will come to pediatric hospital. No child will come to Sora. Give me ventilator. When I have no oxygen, I have oxygen concentrators. It uses 5 liters of oxygen. What do I do? Our OPD is 800 patients per day next to GP1. Day OPD. Night OPD is 400 patients. There are 60 to 70 admissions. What do I do with 12 nurses only? Who will take care of it? It is an administrative problem, administrative issue. We have produced 4 chief ministers from Anantnag. And they have all come and settled down in Srinagar. They have done nothing for us. Kindly discuss these things at that level also, at district level also. Make district hospitals strong. Keep facilities there. We will not refer patients here. I will give you Patanjali ventilators. I was given last year 8 ventilators costing 13 lakh rupees. I said, this is Patanjali, I want servo oil. जहाँ मैंने काम किया है, BJI में काम किया है, AIMS में काम किया है, Sora में काम किया है. I want Mecca ventilators, servo oil ventilators. I don't want this Patanjali system. Don't discriminate us. Take care of fields, make fields strong, make district hospital strong. You will not get any referral. You will improve patient care, child care, and if it is infant and mortality. Thank you.
I have a comment to make. I am Dr. Gansham. I am actually present in Jammu. I think the point, one of the leading cause of the NMR is asphyxia. As Dr. Muzaffar Khan told, similar is the situation in Jammu also. We have around 100 deliveries per day, and patients are in queue. So there is a problem of asphyxia which can be mitigated only if we take in just our labor. Number 2, there is a problem of premature deaths. I think on this forum I request that we have the infrastructure, we have a neurologist. IEP and NNF should be liberal enough to grant us the fellowship in neurology. And we are planning a DM course so that we can produce more neurologists and we can decongest our NICUs. We have level 3 care, but it is over flooded. Instead of 60 patients, we have 120 patients at one point of time. So that we produce more neonatologists, fellows, and we can post them in the medical college so that we can start level 3 care there also, and we have one-to-one patient per rated bomber. So the sepsis is also taken care of. With these steps, I think we can reduce the NMR.
Thank you, Dr. Gansham.
I just want to add, Dr. Nagya, you said Anantnag has more birth districts here. Now, with due regards to my obstetrician colleagues, my gynecologist, our cesarean section has become a commercial thing. It is a commercialized thing. A baby who is born by normal vaginal delivery in a hospital gets birth asphyxia. I have done PG diploma in developmental neurology. I take care of these babies. I get maximum babies birth asphyxia who are born normally. Other thing, there is no antenatal problem here. We have good antenatal care. In Kashmir, यहाँ कोई भूखा नहीं सोता रहा. उतनी poverty यहाँ पे नहीं है. We cannot take care of mother babies. We are not that poor. We are not that poor. Problem is that asphyxia, we have forgotten, our doctors have forgotten normal labor. There should be an audit. आप देखो हर जगह mushrooming of these private nursing homes, commercialization. इतना ये बोलते हैं भाई पानी कम हो गया. योजी रिपोर्ट आता है आपको कम पानी कम हो गया, काटो पेट. Don't do it. We get maximum problems from those places. So in our hospitals, you should be, normal labor should be encouraged. If you have golden card, if you have schemes, give scheme to doctors who perform normal labor. LD hospital, my hats off. LD hospital is the only hospital which gives a trial. And in Anantara, John Bishop Memorial Hospital is the only hospital which gives a normal labor trial. We have 12 nursing homes, they will give trials.
Point well taken, sir. Point well taken. Thank you, sir. And just a minute, sir. Just a minute, sir. I would like just to respond to one point of Dr. Mushtaq, that the government, I think, have already taken the cognizance of this thing, what he was telling, and they are planning to establish AIMS. That is a much bigger institution than any maternity out there. In Avantipura, that is in between Srinagar and the Anantnag. So I think government is already has recognized the fact. Now, before coming to you, sir, because Dr. Arun Singh, he is our guest, he has been staying for long. I'll give to him for a while, then I will come to you, sir. I'll come to you.
First of all, I would like to thank the panelists and also the point which is raised. Now, I think the issue is not of Anantnag. You see, up till now we were deliberating that everything is an administrative issue, and if we can tone the administration, the implementation, things will get solved. I bring in this conclave a new perspective. अगर कोई चीज implement नहीं हो रही है, so go back and think why it is not getting implemented, rather than think every time that we will get it implemented. There is a learning from the people also. If they are not listening to us, what went wrong? So first and foremost, I think it starts from the planning stage. So I am going to raise some very small issues, because this conclave should not only be an implementation issue, some new ideas must also flow. Whether you would accept it or not, that is another thing, but let it be placed. But the first thing is, in this country, we have one doctor. I am talking about private government together, versus 1.2 nurses, versus 1.3 technicians. And all the politicians are talking today, we must produce more doctors. You go to any of the Scandinavian countries, which started much later, they didn't have a single doctor. When this country became independent in 1947, we had medical colleges. But the king of Sweden, his child had to be delivered in Germany because there was not a single obstetrician there. So try to understand there's a learning which is not always there. So how did they do it? With due respect, sir, let us plan it. There are two forces which are required. One is a neonatal nurse and one is a midwifery nurse. We have to designate it and tell. And neonatal nurse doesn't mean only in SNC. When a child is born, from one person, two people are coming. One is the care of the mother, one is the care of the newborn. So there should be two nurses there. One to take care of the mother, one to take care of the newborn. If this basic thing we don't, and we require technicians to run the ventilators, why should a doctor be worried about that the tubings needs to be changed? So the third is 1:4. For every one doctor, we should have 4 nurses as a state planning, and we should have 6 technicians. Sir, if you have in your NIC technicians then 90% of the doctor's load is solved. Because you don't have to worry about tubing kahan se aayegi, change kaun karega, this. So there is something called, which West Bengal did, critical care training to non-doctors. This will support your system, it will create efficiency. That's number one. Number two, sir, there are 3 reasons of deaths, we just said. Number one, tops the list is preterm. I have a different suggestion. Do we want to understand the definition of preterm? When we were students, we were told preterm is less than 37 weeks. Where did this study came from? Who defined it? Is medical science a Bible and we are a holy priest? So when I went into deeper details, it was lung maturity was deciding, but we are Homo sapien. We are not a pig or a cow. So it was found, Americans were very intelligent. They changed the terms. They said full term is 39 to 41 weeks. Now sir, try to understand. Full term is 39 to 41 weeks. Then why did we say term as 37 weeks? So one liner, if you all agree, do not deliver. Tell it to the people. Ultimately, it is not doctors. It is the people with which you go. That we have taught you wrong. Term is not 37 weeks. Term is, unless until there is a medical emergency, please wait for 39 weeks before you terminate. If this simple message can go, then your preterm will change. And there are American studies which did this simple liner that don't deliver a baby because you are interrupting the brain formation. The brain keeps on forming till 39 weeks. Every minute, 40,000 neurons are getting made. So, if you are cutting it, you are actually creating a problem. Number one. Number two, we are talking of nutrition. One of the commonest reasons among doctors to produce IUGR children, to preterm children, it's not a question of nutrition, it's not a question of antenatal care. It is maternal stress. So the best paper has come that we don't have a pipe from the mother to the newborn, that whatever mother eats goes to the newborn. This is a myth, this is a dogma. If the mother is stressed, then whatever may be her nutritional status, that will not go to the baby, because that is how the fetal placental circulation is based on. Can we have a line? Don't quarrel with a pregnant woman, even if she makes a mistake, in our offices. This is India, sir. This should be our contribution. This was a part of inherent of our culture. If it is not written in lines, just think about it. This line will. The third thing is dental care in antenatal children. If a mother has caries, there is a 30% more chance of producing a preterm delivery. Can we have this very simple? There are a lot of dentists who are unemployed today. Can we talk and employ them in our antenatal care that they take care? So, if with these 3 things, maybe our preterm births could be reduced. The second thing is the labor room. Now, I hear this debate of cesarean section versus labor room. And let me take, if people are preferring cesarean, it is we are at fault. We the doctors, we advocated that cesarean section is safe. In delivery, normal delivery, we have done this for decades. Earlier, mothers would not prefer cesarean. They would prefer normal delivery. We switched them. Now, I have one request. Sir, I do not blame the obstetricians. Yes, there is a commercialization, but that's the government's choice. Assured health versus insured. Mother and child should be an assured health. If that is a different matter, but what I am just saying, if you want the cesarean section to really come down, change your labor rooms. If I was a mother, I would not deliver in the labor room, which is there are 3 mothers delivering. No part of the world does it. On one side, you are so careful with the woman's dignity. On the other side, you put a curtain where one mother is crying, which produces a stress. Sir, all countries have switched over to LDR, labor, delivery, recovery. You put a birth companion, decrease the light, decrease the sound, normal delivery will progress. Or in other words, if you want to stop the normal delivery scientifically, खाली दो काम कर दीजिए, लाइट बढ़ा दीजिए, साउंड बढ़ा दीजिए और माँ को डांट लगा दीजिए. In your notes you will say failure to progression of labor. Please take up this case for C-section. Because what we didn't understand that delivery is not a physical process of cutting the abdomen and taking out the child. It is a neurocognitive question. There are hormones which are sensitive to the environment. If there is excessive light, the melatonin stops, and that melatonin will not allow the oxytocin to be released. So there is a relationship. I always say, instead of using the word essential, India should use the word physiological. There are so many mammals who are delivering. Let's learn from them. What is the physiology? How can I be a better doctor than nature? Learning from nature is what everything comes from there. So one principle is, can we change the labor rules? And we don't have so many doctors. So we have midwiferys, we have technical know-how. The mother should feel comfortable. One line. If the mother feels comfortable, sir, breastfeeding will come. Mother's dignity is protected. Even animals do not deliver if there are two animals to deliver. I went and spent my time in veterinary. Calves don't deliver if you take away privacy. Because the moment privacy is taken away, adrenaline and cortisol levels start decreasing, which stops the labor. So this is a normal physiology. Perhaps it is a time just to remind you. The second thing is, if you give a doctor to deliver, and I must be very honest that this is a place I didn't think of speaking, but all of you stimulated me to speak because you're speaking so honest. If there's 100 mothers to deliver and I am a doctor, I would like to cut my times. Half an hour is taken for a cesarean section or 1 hour. A normal delivery may take 24 hours. Sir, 24 hours, I call, if you have to walk 30 centimeters in 24 hours, then you understand normal. That's the distance a newborn takes from delivering from the mother's womb to the outside. Can we, sir, allow more LDRs? If we can plan lakes, if we can plan tourist spots, let us plan for the future of our state. And for this, if we can, this is the temple, this is the mosque for my newborn. Can we have a beautiful LDR room where there is music, there is light, the mother, there is a companion. If she wants to listen to anything, including the prayer, let it be given the liberty to hear. Let her walk. Sir, I have done it in 5 minutes. I would invite you to visit Dharampur. I would invite you to visit Vadodara Medical College, where not a single man is told, why would the word labor is wrong? There is no physical part of it. It is a very natural phenomenon in which the mother is happy to do. Sir, if we create this and not create a conveyor-belt system in which you are asking a doctor to deliver, then we are asking them to cut time. The private sector has cut time. I don't blame them. How will they? So, because normal deliveries are costlier than cesarean section, if they have to be done properly. My next thing is, sir, cutting on induction and augmentation will directly lead to I don't believe it because आपके पास नहीं है कि 24 घंटे उस माँ को हम ऑब्जर्व करते हैं। और पेरेंट्स ने भी आप सोच लिया है कि अगर मदर भर्ती हुई तो शाम तक बच्चे की रोने की आवाज सुननी चाहिए। अगर नहीं हो रहा है तो इवन पेरेंट्स डिमांड कि आप कर क्या रहे हैं, अभी तक बच्चा क्यों नहीं आया। तो ये बताना है कि द स्पीड इज डिसाइडेड बाय द मदर एंड द न्यूबॉर्न. We as doctors are only to ensure that it is a normal and nothing abnormal comes. We are only going to intervene when there is something. When to cut the cord? The whole world is debatable. किसी ने कहा 45 सेकंड के बाद काटिए, किसी ने कहा 1 मिनट के बाद काटिए, किसी ने कहा 5 मिनट के बाद काटिए।
Sir, I have a request, sir. Sir, I have a request that we have lined up sessions after that. Could you this is a request, sir.
Then I stop because I had, as you have a very long lecture, either it should be divided intermittently.
Sir,
As I told you, I am not talking about administration, sir. So thank you very much for giving this.
Thank you, sir. Thank you. We will take one last questions from Dr. Tajamul, and after that we'll break for tea.
With due regards to the panelists and the audience, I would like to say one thing only, that unless and until we don't improve the district level, I mean to say the peripheral level, healthcare system, things won't get up to that mark which expect. For example, I will tell you regarding my district, taking into consideration the topography of district Budgam. Recently, what I did with under the aegis of Directorate of Health Services Kashmir and with regards to Health Services Kashmir, we are proposing 2 first referral centers. One we have already established at Chadura for 4 blocks, and another we are going to put at Mahagam or Kabir. Regarding the referral, we were talking here, since in tertiary care hospitals there is a fatality and all, but in the district hospitals, the sub-district hospitals, the PHCs, there is only a single doctor which has to take a decision regarding the referral. So, in the result, at times there is a problem, timely referrals and whatever we are talking about. Number 1. Number 2, we have to increase the manpower here and we have to rationalize the manpower. From this platform, I request my Director of Health Services Kashmir that the staff needs augmentation. They need trainings. For example, in District Hospital Budgam, we are having an SMCU unit. There is a single pediatrician which there has been kept for running the SMCU. So it's very inhuman and not possible for a single pediatrician that neurologist, whatever you can say, to deliver up to the mark. Second thing, the staff which has been kept there or which has been which are being delivering the deliveries there, that's minimum. Now, if there would have been a proper staff, we would have trained them for timely basis so that the referral would have not taken place. So that is to be taken into consideration. And third thing is this, that regarding which we are talking about the nutrition and all. Our Ashas, they are doing a wonderful job. They are the backbones, all salutes to the Ashas. And each and every program whichever is to be run, that is to be run by the Ashas. And they too are counseling the pregnant ladies. And here I would like to say that preferably the primaries, whosoever comes for the antenatal checkups, our gynecologists, the medical officers, the paramedics, they should counsel them for going for a normal delivery, which previously used to be here in our UT. Now it has changed. Simple example I will tell you. I was recently at a first referral unit at Chadura at around about 5:30. There was, everybody was, a person came, entered the room of the BMO screaming and all that. His daughter has been kept since afternoon for this, she was being given the trial for normal delivery. And there was such a situation at that time, and I told my consultant gynecologist to go for a cesarean. Because it's that person who is in the field, who faces those things. So for that, it needs proper counseling once they come for the antenatal checkups. So that's my point.
Thank you, sir. Thank you, sir.
From this side, whenever any untoward happens, at that time everybody says that it is the doctor's negligence medical negligence. And nobody talks about the revenue negligence, the police negligence, other negligence. Why negligence only for the doctors?
Thank you, sir.
They are doing a commendable job which we have seen in the COVID.
Oh, thank you, sir. Thank you.
Kindly, I think that this point should be raised. Simple, with unintentional, just by chance, some injection failure and all, and they say us negligence. That is not acceptable.
Thank you, sir. Thank you so much. We close the session. Sorry, sir. We are already short of time. We have already crossed the limit.
So we can take these discussions outside.
How many of us have been born by cesarean section? Please raise your hand.
Sir, we can discuss it after. We have more sessions on paternal, so we can discuss on that.
I would like to thank all the panel members and the audience for an interesting session. Now I request Ms. Prajni Char of Character Planning to felicitate the panel members with the mementos. Thank you everyone. Now we can proceed for tea for 10 minutes. And let's meet Mir Ahmed. The tweet is the first 28 days of a child's life, the neonatal or newborn period, carries the highest risk of death. It is also the most dangerous period of a newborn mother. Coordinated efforts need to address the challenge. The first 28 days of a child's life, the neonatal or newborn period carries the highest risk of death. It is also the most dangerous period for newborn's mother. Coordinated efforts need to address the challenge.